Hello, welcome to our, I think it's our third GIRFT Community MSK webinar, this time focused on Community MSK, Community Appointment Days. My name is Andrew Bennett. I am a consultant physiotherapist in Sutton, southwest London, and I'm also the National Clinical Lead for GIRFT for Community MSK, and taking a clinical lead role in our community delivery programme. Thanks for taking time out of your busy days to attend this webinar. It is being recorded, so if you have to drop off early or you'd like to watch it again, or there are colleagues who are unable to attend, we should be sharing the link in the next couple of days. And we've got some great presenters, and I'm sure as the webinar goes on, people will be keen to ask questions. So there is the opportunity to ask questions within the chat. Some of the speakers may try and answer those questions as we go, but of course it's always tricky. And my colleague Luke is going to chair a brief Q&A at the end, and some of those questions may inform that. And we will review the questions at the end of the webinar and put out an overarching response. Next slide, please. So I'd like to thank also the team for organising this webinar. They are not easy things to organise, and all our speakers. I think it's fair to say there is a significant interest in community appointment days. We've seen that through our community delivery programme, working with 17 systems to help them reduce their 18-week backlogs. And a number of those systems have used the support and resource we provided to deliver community appointment days to help do that. But of course, these are not just waiting list initiatives, far from it. They are a new way of working, a new holistic form of care, and there is loads of interest in this at multiple different levels, from NHS Confed, government level, within GIRFT, within media, and right across regions and systems. So I think it's really timely to reflect on these, and we've got a fantastic range of speakers who are expert specialists in this area, and have led the development of this way of working, who are going to follow. But part of this work is very much a collaboration between us in NHS England and GIRFT and colleagues in the Joint Work and Health Unit. And as such, the first person I'd like to introduce is Caitlin Thomas, who we are working very closely with regard to our community MSK work, who's going to provide a brief reflection on a recent visit to a CAD, and then we'll move through our list of speakers as shown on the screen. So thank you all again for attending, and I hope you enjoy and get a lot from this session. Kate.
Thanks, Andy. Next screen, please, Callie. Just wanted to introduce myself. My name is Caitlin Thomas, and I'm the head of MSK Policy Delivery within the Joint Work and Health Directorate. If we go to the next slide, just to give a bit of an overview in relation to that directorate. It's a directorate that was set up between the Department of Work and Pensions, Department of Health and Social Care in 2015, just in recognition of the significant link between work and health. And our work broadly covers working across the whole of the customer journey to help disabled people and people with long-term health conditions who want to work be in the best possible place to do so. And that involves looking at employer behaviour, managing sickness absence, and providing good access to good quality occupational health provision, as well as looking at health and employment support. Some of the work that we're involved with includes employment advisors in NHS Talking Therapies, Disability Confidence Scheme, occupational health, work well, fit to note, and statutory sick pay, and crucially, and for most relevant to today's presentation, MSK interventions. If we go to the next slide. I don't think I probably need to cover this with most people on the call, but the links between MSK and work are really strong. As you well know, over 17 million people in England live with an MSK condition. And for people living with that, that's the leading cause of years lived with disability in England, and accounts for up to 30% of GP consultations, with waiting lists in MSK community services being incredibly high at around 350,000 as of April 2025. In terms of the economy, that impacts us significantly, with around 26.5 million working days being lost in the UK due to MSK conditions. If we go to the next slide, I wanted to just give you an understanding. So in the Joint Work and Health Directorate, we've been working with the GIRF Community MSK team to support the Community Delivery Programme, which was launched back in December 2025, working with 17 ICB areas. This has been an incredibly ambitious and fast-paced project, and it's achieved some really dramatic results, principally through the work of the CAD days. We've been trying to better understand in the Joint Work and Health team the approach that GIRF have been implementing in their Further Faster model, in particular looking at how that aligns with the work that we're doing to set out 3 shifts that have been articulated in the 10-year plan. So looking at treatment to prevention, hospital to home and analogue to digital, as well as looking at alignments with the Get Britain Working white paper. As part of this, then, different members of our team have had the opportunity to attend some of those CADs, and our thanks go to the teams in Cornwall, Brighton and Tower Hamlets for welcoming and hosting us in these visits. For all 3 areas, there have been the most amazing and incredible levels of organisation that we have seen and have clearly gone into making the events happening. From the quote that I've put on the slide, just from one of our team members, these CADs felt truly centred person, really patient focused, and there's been a high levels of professionalism and enthusiasm displayed by the team members throughout. In terms of one of the programs, we were able to buddy a patient through their journey, which meant that we followed a patient and through a session on what matters to you, an assessment of their specific MSK needs, as well as supporting them to understand what their rehabilitation needs might be. In one of the locations, there was even an opportunity right at the beginning of the journey to also assess for other health issues in a very light touch health check. What we've been completely blown away with is really about how there was engagement across the community and voluntary services, and there were representatives from the wider community support services represented, which included physical activity sector, employment support and other services to help patients in the management of their condition. I just wanted to steal the thunder of one of the team members from Barts Health who ran the Tower Hamlets Day. They gave a write-up of their event, and they said that 8 weeks worth of patient care was achieved in one day at the first CAD that they hosted. And Simon Cannon, who's deputy head of therapies from Barts Health, noted this has been about more than reducing waiting lists. This has demonstrated how healthcare can be delivered closer to patients, making it more accessible and less intimidating, while focusing on prevention rather than just treatment. And from our perspective, and the perspective of the 10-year plan, this is exactly what we're trying to achieve. We've been really incredibly impressed by what's been delivered by the ICBs and the work of the GIRF team to enable the CADs. And as mentioned, we're really keen to understand what works and whether these CADs might form part of business as usual. We've got lots of questions still. How can we accommodate people who experience neurodiversity to be better accommodated? How can local areas identify locations that they can use on an ongoing basis? And also, when might employment support be best implemented within a CAD day or a CAD user journey, if you like? I know that this webinar will provoke a load of questions, and we're really keen to understand what they might be. But what I'm going to do now is hand over to Laura, who's going to move you to the next section.
Thanks very much, Caitlin. Lots of music to my ears around how the CAD days are taking off. Really, I'm Laura Finucane, and I am a consultant physiotherapist. I'm currently working as an expert clinical advisor for here. At the time that we started our journey with the CADs, I was the clinical director for Sussex MSK Partnership, which no longer exists, but that's a different story. It doesn't really matter. It's been succeeded by MSK Health, Sussex MSK Health. So I'm going to give you a little bit of background about how we got to this point of developing the CADs. And you're absolutely right. This was about an experiment in doing things differently, but really based on very much on the current landscape. You know, that landscape of the increasing global burden of MSK conditions, on that backdrop of an aging population with increasing prevalence of major conditions, and really, you know, our need to do things very differently in a healthcare that is in crisis. So next slide, please. What we felt was that we were really hitting the target, but missing the point. Actually, what we felt was that we recognised that we were delivering a really good, efficient quality service, but which was probably much more about productivity than actually the person that was sitting in front of us. We knew that the current way of working was pretty unsustainable, with long waits and clinicians feeling really pressured in what I would describe as an industrialized model of care that really focused on productivity rather than that person sat in front of them. We also recognised that people were coming with much more than just that MSK condition, and that often required multiple appointments, often bouncing around the system, you know, in a single way. We recognised that if we wanted to support people with their MSK health, we had to understand those social determinants of health. Next, if you just press the button. And actually, if we understood them, we'd also need to do something about them. It's not enough just to say we recognise them. We really wanted to be able to deal with some of those issues. And we wanted to deliver a different model of care that really put the patient at the heart of and focusing on personalised care, not just a tick box, but a cultural way of working for both our clinicians and non-clinicians. And as an organisation, we really had a really strong culture of personalised care, but things were getting in the way of actually delivering that good personalised care. So the CAD was really a result of speaking to lots of people. It was co-designed by the community, our staff, people with lived experience, and patients. Next slide, please. So the CAD, it was very much about everyone having a what matters to you conversation. We invited in the region of 300 people to attend on each of the days that we did our community day, and essentially really focusing on health promotion, prevention, and access to local community services that could support people depending on what they needed. And those what matters to you conversations were absolutely critical to really making sure that we got the focus right. So the what matter to you conversations, these are strength-based conversations which recognises the experience that individual brings and works in partnership with the clinician to decide the next steps. And in a way, there's a real magic to that, you know, and that magic of that what matters to you conversation is within that sort of careful, kind, and unhurried sort of nature of the conversation. So, and we recognise that if we got that bit right, everything else would follow. We wanted to meet people in the community, so we hired a community space. We wanted them to have access to a range of things that would support them, including health checks and full assessments as required, rehab, whatever it took. And those conversations were held in a very much a conversational style. There were no time constraints on how long someone could spend with a person, whatever it took, whatever was right for that individual. And you know, individuals could choose to access as many of the areas that they needed or wanted, depending on what fell out of that conversation. We also wanted to really think about note keeping not being necessary unless we really felt that someone needed a one-to-one assessment, and we had specific criteria for that. So we provided them with our passport, which you can see in the middle of the picture, which basically allowed people to write in the passport. So they had a record of what was going on, and we would scan that into their notes at the end. So we would also have a record of what happened on that day, and we would help people to do that. And individuals, essentially, we asked our staff as well to really think about not coming in uniform, but coming as they were, so on an equal footing and equal partnership with our the people we were serving. So next slide, please. If I have to give you some sort of impact, you know, if we looked at our first 2 pilot days, and this was back in 23, so we've done about 15 or more of these CAD days. But essentially what we saw in those first 2 days were we saw a significant number of people. In fact, we saw 3 times more new patients than we would in a normal working day on those days. We also saw that people, around 50% of people were put on a patient-initiated follow-up, and essentially they got what they needed in that room on that day. We followed people through that journey through PIFU, and our rates are, I think, are really compelling as well. 10% return at 6 months, 20% at 12 months, with an average return of 50-day return. And of course, the waiting list did reduce, and for me, it's very much about, as music to my ears, that people are saying it's not about a waiting list initiative. That's absolutely right. It was never about that. But I think because of some of the ingredients that we were providing in this way of working really helped to drive those waiting lists down. And I'll talk to that in the next slide. So we came up with this, what we felt was essential ingredients to make that day work, to really focus on individuals and really think about what was important in that event to make it work, and as a consequence drive those waiting lists down. So if you just press the button. So if we look at the personalised and humanisation of this, we really wanted to remove any of the barriers that are getting in the way of really good care. And we wanted to make sure that we saw that whole person. So by taking away some of that, sort of demedicalising that intervention, that would really help. And then really understand what really matters to that individual, and to be able to respond to that. And I think this is one of the really important parts, is that we can understand when someone's got more than just an MSK condition, but in normal practice, what we would do is we would signpost that patient. What we wanted to do was to go, well, actually, we can deal with this now. We can actually help that individual navigate some of those difficult systems sometimes, and support them in that journey. If you press the next button, this was very much about moving from a consultation to a conversation. Again, talking about that demedicalisation, really thinking about it being really community powered, and for us to let go of the ego of really engaging and being an equal partner with individuals on this journey, so that we could work with them, really embracing the kind of skills that person was bringing with them, and leaning very heavily into the community voluntary and community services that were available in the community. Next button. So finally, sort of really being purpose-led, we really wanted to make sure that we looked at our data and really understood our data in terms of who was accessing us, and more importantly, who was not, and how could we ensure that we could get to the people that really needed us. It had to be a local flavour. So we made sure that those community services and voluntary services responded to what that local community needed. And this was about everyone. It wasn't just about the people we were serving, this was also about our staff. And underpinning this approach was really, kind of making sure that we listened and we consulted. We were really clear and devolved that decision making, but we were really comfortable to fail fast. If it wasn't going to work, then that was fine. We would live with that, but we would always continue to think about how we could do some of the changes. And finally, the final slide from me. This was very much about our staff. This was very much about really recognising what they were bringing to the party and making sure that they were comfortable in delivering this model, because we were asking them to do something very different, and it allowed people to have that connection with each other. If we look at the feedback from our staff has been pretty amazing. They've enjoyed the journey because it has been different. It's been really different. So finally, I'm just going to finish by saying we've been working really closely with GERFT in looking at the ingredients and trying to think about providing a checklist or principles on how you might want to design a community appointment day. And Chloe and Georgia are going to speak to that piece of work. I'd like to hand over now to Matthew and Brent.
Brilliant, thanks, Laura. Great, so I'm just going to talk through. So Brent and I both work in City and Hackney in East London, and so we'll just talk through our experiences of sort of our approach to Health and Wellbeing Day. If you go to the next slide, please. So we're really fortunate in terms of, and I say this as we are really fortunate in terms of we have sort of a really established and mature MSK service. We've got a large group of physios, a large group of advanced physio practitioners delivering sort of that expert assessment, point of care ultrasound, and sort of those additional skills such as injection therapy. City Hackney sits across 8 neighbourhoods, and we're fortunate to have a really large first contact physiotherapy workforce that works across all 8 neighbourhoods. So we really try and support patients through that initial consult all the way through that service. So where this idea came from is actually in terms of how can we take some of those experiences that have just been talked about in terms of really deliver something a bit different. So what we was able to do, as you can see from these pictures, in terms of hire a space within our town hall in the middle of our borough in Hackney. So there's sort of that first picture on sort of in the middle is our atrium where we led our sort of physiotherapy session, and then the space upstairs, sort of a bigger area where we had our community services. If you go to the next slide, please. So what we want to try and do is absolutely, so in terms of looking at all the things that Laura just mentioned, and actually if you just click it on a second. Perfect. So again, very much actually, so this was our second event in 25. We did do one in 24. It was very much inspired by all the work that Laura just talked about in terms of what's been going on in Sussex. But actually we're very much in terms of actually having that what's most important to you conversation. And what we wanted to do was actually, I don't want to say this wasn't a waiting list initiative as the things that Laura described, but actually we did know from the sort of the information we saw, actually we did have a growing waiting list issue. And we did know that actually there's some potential benefits from there. But it was very much actually wanted to collaborate with our sort of wider teams and use the expertise that we have with our service. So this is fundamentally how we set up our sort of our days in terms of we wanted to discuss what we do as a service. We wanted to address sort of MSK issues, give people the opportunity to see a physio on a day, and do various different settings across sort of the interventions, again, improving vaccine uptake and health checks. We also wanted to sort of interact actually how we work as an ICS or an ICB. Simon Cann has been talked about. We sort of work very closely with Simon actually. How can we sort of work our way through these initiatives to deliver the best care possible? So you move to the next slide, please. So I don't want to say we made this up, but we did to a certain extent. We sort of made it up and went along and we tried to be iterative as we've done. And what we tried to reflect is actually here in terms of within these slides, it's some practical elements of what we found worked. So therefore, obviously, how can we share and learn across the board? So this was atrium as we came in. So as people came in, there's a range of chairs that people sat down. First of all, listened to a presentation about their conditions, then moved through our front of house zone into sort of a clinical area where actually people could be assessed. Again, as Laura illustrated through that subjective discussion, but also we did have some zones there in terms of that clinical assessment if there's concerning features. Then at the back then had a lift to our first floor that went up into that that bigger area we talked about. The next slide, please. And then again, upstairs, we had approximately about 40 services upstairs across the borough in terms of, again, laid out as the structure you could see. And then next slide, please. And again, we tried to get as many different services as we could, again, across all the range of different services, as you can imagine, in terms of not only those just related to health, but in terms of those regarding housing, money, and mental health, that we know are the common themes that our patients will present to us and talk to us about. So it's very much how can we link all those services together. What I would say is actually very much, again, this was a collaboration between us and our primary care colleagues across the pathway. So actually very, very much sort of held that physiotherapy side in terms of our assessments and discussion. But actually then the collaboration upstairs was very much led by our primary care colleagues. That's actually how it came together. So certainly all these services, yes, we had an input, but actually I certainly can't take credit for sort of that organisation. That all came from our primary care teams. The next slide, please. And then actually in terms of we set our days out slightly differently. So we had almost kind of routine physiotherapy in the morning, then the afternoon in terms of when we set that out in terms of those a bit more persistent pain and actually segmented in terms of cervical conditions. And then obviously you can see the sort of staff mix that we had. And then next slide, please. And then sort of my final bit was in terms of before I hand over to Brent, in terms of actually, again, we try to really iterate that message actually again as Laura said, what is that most important thing for me today? So that message was continually discussed, but also again, we did offer lots of education regarding in terms of the role of MSK, but also kind of screening and making sure people are aware of concerning symptoms. And then over to Brent.
Cool, thank you. Next slide, please. Great. So I think, like it's been mentioned, I guess there is the key thing of that. What's the most important thing to me for the patients, but also we did see a bit of the impact on the waiting list. So it was an initiative for us to actually go through and do a lot of validation work. So we screened a lot of those longest waiting appointments or people on the list, deciding and seeing from that who's appropriate and who's able to come into these sessions. And just a little part of that we're able to then offer appointments to these people. There was a lot of those conversations around, do you still need this, and those people that had been sitting there for quite a long time that actually decided they didn't really need it, or there was more some admin issues that we were able to validate. So there was a part of that as part of the waiting list that definitely formed part of the whole process. Next slide, please. So just a bit of an overview, quite a busy slide with numbers and lots going on in terms of the morning and afternoon sessions. But I think a couple of the key messages to come out of that. So we had 220 people booked in for our day. This was just the physiotherapy side downstairs. So we had 70% of those people attended. And really key, I think, the stuff as well with that of being able to talk to these people, have that discussions. 20% of the people that came into the day then actually decided they didn't require any further input. And we're able to also use our classes and other avenues into physiotherapy to try and help get these people into that right places first time. So we can have that discussion, and they're able to do that with the physio team. Next slide, please. And then upstairs, so as Matt said, there was up to 40 services or so that we had. So as you can see, there's some pretty big numbers. One quote that sticks with Matt and I through this, there was a dietitian that was working upstairs and who was describing the line of people around the corner of Hackney Town Hall. As the only time he'd seen a line that big was when he was lining up for the Beyonce concert. So that was a good reflection of how popular the day proved. And I guess when we offer these services and give them to people to come in for, the people definitely came. And as you can see in the quote there, other services, so the bowel screening team that has said probably the most they've been able to give out the test kits to all those people and all the conversations they were able to have. Next slide, please. So we were really keen to get patient feedback on this. So out of those 154 people, we had 125 feedback forms, and these are the questions that we asked. But I'll go through them individually as we go. So we're just trying to get a good gauge of, I guess, how the patients felt that it went and whether they'd feel they'd benefit from this again. So next slide, please. So I think really positive stuff here is looking at that overall experience, 98% of people saying it was good or very good through the day. And the key thing, do you feel involved in your care, that 94% of people said yes to that. So I guess those are two pretty key metrics that we were hoping to get out of it. Next slide, please. And just moving on, so we asked the question of, would you rather wait 6 weeks for a traditional physiotherapy appointment or come into this session? And so again, just under 90% of people said no, today was helpful, they'd prefer that. And again, the same thing, just under 90% saying they would attend a similar session in future if it was offered. So I guess we go into these and there was a little bit of anxiety around how will the patients react to this, or the service users. But actually, this is showing a really positive response to the days and what they're feeding back. Next slide, please. And the final thing of asking that question, did we answer the question, what was most important to you? 88% of people saying yes. So again, that real key thing that we're trying to achieve right at the start, hitting those in really high numbers. And also again, that lots of people saying they are clear about those next steps and they were given the opportunity to answer any questions or ask any questions. So really, really happy with how that feedback came in. And I think the final one, moving into the last slide, was just a word cloud. So we gave the patients a free text box and a chance to put any comments they had. So as you can see, they're reasonably positive, good and helpful being two of the biggest words in there, which is again a really good advert for what we're trying to do. But I think probably echoing what people have other said, the staff feedback was also super positive. So really happy with how that ran together. And I think that's at the end of ours. There's a couple of slides in terms of the passport that we use that can be shared, and we can have a look at that afterwards. But I think probably time to hand over to Sam.
Thanks, guys. Hi, I'm Sam Wilson. I'm the lead commissioner for MSK services, amongst other things, in Cornwall. The Isles is silly. And I've also got with me today Maria, who's from our main MSK provider, who's been delivering the community appointment days for us in Cornwall. Next slide, please. So we actually visited Sussex last year at the ICB, and we came back to Cornwall and said, this is what we want to do. We had already run super hip clinics and knee clinics, and Maria's team had a look at those and said, right, we want to do something for our spinal community. From there, we had, I think, the first spinal one in the country, and we've had subsequently 3 more community MSK CADs, and the last one was a week ago in this very location I'm sitting in now. So our motivation, like other areas, is to enable people to wait well, live well, work well, and really try and provide some of that holistic support around it. We find that our community providers and the clinicians in the community are some of the best at asking that what matters to you question, and finding out that patients have much more than just a medicalized health physio need at that point, but there are more things we can link them to. The community appointment days are massively successful in themselves. We've found that we've had minimal DNAs so far, and considering for a rural location where we're asking people to come to a central point from quite remote places, that's fantastic. We've had 279 patients attend over the first 2. They receive health checks when they first come in, BMI, and also blood pressure, things like that. Then they go in straight into the what matters to you conversation. If they need more physiotherapy assessment or one-to-one rehab, we have zones for those too. Out of the 279, 161 required ongoing physio, 30 required no further input, and 88 were actually put on patient-initiated follow-up pathway. What I will say is, on those days, they will have had probably the equivalent, because of the community village we have at the end of the day, which is, it kind of flows through a room. So we're calling it the gift shop at the end of the roller coaster ride, where people kind of go through the community village and are able to access multiple support services. But people are getting the equivalent of 6 or 7 touch points in one day. That could have, it had to be extended over weeks and weeks and weeks. That also is a massive saving in travel for patients in a rural location like us. Next slide, please. So as I said, some of this we have that kind of flow with the zones like most people do. We also quite happily stole the idea of the passport and the scanners from Sussex. And we're happy for anybody to steal our stuff too. I think the 2 bits of the day are that first part for me of the what matters to you conversation being the absolute key bit, and that community village at the end. We can have everybody going through the services, but unless we're offering that support to people as early as this pathway, if we do have patients that do need to go on to other services, referred into interface services or secondary care at some point, we have managed to try and optimize patients, both medically and with maybe some of their psychosocial needs, at a much earlier phase than we might have done before. That allows our secondary care colleagues to not have to do as much pre-optimization as well. Next slide, please. So the community village, as I say, this is the thing that I think makes it sing, and I think you'd agree with it. It's fantastic to have our MSK clinicians delivering all their services, But to be able to send somebody to fuel poverty, to healthy Cornwall, smoking cessation, one of our PCNs comes along to our the community appointment days. Anything you can think of. We have our talking therapies team set up in separate rooms on the days, so that if somebody needs a more intensive talking therapy session alongside health coaches that we've got there, we can provide that for them. And it's that handover with the passport from the physios who are doing such a fantastic job, that physical handover that works so much better than sometimes what we do is hand out a leaflet or give them a text. It's really showing them that they can have all of the support around. Next slide, please. Okay, so that's just to give you a graph of the amount of patients we've seen so far and different on the community village attendances. As you see, it's a healthy spread across a lot of areas. Next slide, please. And again, patient experience, we've monitored that as well. And we have got multiple positive reactions. The feedback forms that I tend to visit and read at the end of the day when I come down, because it's a big boost for us at the ICB to be a part of these days as well. It's really heartwarming, and it's near universal approval from patients. Next slide, please. Obviously, we'll share these slides after the thing, but it's nice to be able to actually have some of these quotes here. I think, what was the quote that you used about the miracle?
My miracle happened. Everybody here helped me.
Yes. So hearing something like that at the end of the day from a patient is wonderful. And it's not just for patients, it's for staff as well. So if I can move on to the next slide, please. I think I'll talk a little bit more about that. Is that we come down, myself, my boss at the ICB, we come down and we get involved. So we're directing patients around, we're speaking to patients, we're helping with the flow on the day. It sends us home with our positivity tank completely topped up. It reminds us why we're doing the job that we're doing in the ICB. So being part of that is a huge benefit. And I think that's the case for all the staff. It's incredibly good for team bonding. You get to see people in a different environment, and it can support battle against some of the isolation that sometimes clinicians feel, especially when we're working kind of on our own in clinic rooms. That's what kind of tends to happen. What I will say is the cost as well. After we used the investment from the GERFT team, we put some money towards screens and some other scanners and things like that. It is essentially, we worked out the one in May cost £15 a person. Now for 6 touch points, that's not bad. It was done on a work day, so there was no extra additional staffing costs. It was essentially room hire and moving people around. Moving equipment around. That is a really economically valuable way of delivering services. And on those days, as I said, 6 or 7 touch points can lead to 600 or 700 appointments equivalent throughout the day. I think if we can do it in Cornwall with a rural demographic, I think it can be done anywhere. And I think what we've tried to do with it, as we were, and probably not the best word to use in the NHS, but we were infected by the enthusiasm of Sussex, and we're trying to infect everybody else with these. So we've already had our podiatry team coming to visit. They will be doing their first community appointment day next Thursday. Our speech and language therapy teams have looked at it. They're trying to develop it. Community rehab, our colleagues in Devon will be coming down to visit soon. And it really is about infecting that enthusiasm across the service. The senior leadership at our organisations as well has really bought into this as the new way that we can really deliver fantastic care. Next slide, please. I think that might be it. So I will hand over to Chloe and Georgia.
Oh, thank you. So from the brilliant speakers before us, it's really clear here we're all here to support a system that sees the person, right, and not the body part. And as Sue Brown from Armour said, an elbow, or today in an example that I'm going to give, a hand never walks into the room. So I'm Georgie Dawisa King. I am a mum, a daughter, a wife, a friend, a nature lover, and I'm also an advanced and first contact MSK physiotherapist, and I'm head of personalised care and population health in the Sussex MSK Health Service. And as Laura said, so alongside Laura, Karen Cox and Natalie Blunt, I helped to create what we now know as community appointment days, and I led on the growth of the What Matters to You section. As the word of CAD spread, we found many teams across the country reaching out, wanting to understand what the ingredients were. And over time, we heard and saw loads of varying versions of CADs. And some were not all versions that included everything that made them truly different. So Chloe and I and Gert have worked together to create a checklist, which isn't meant to be perfect or prescriptive, but as a scaffolding really to help others understand what makes CADs unique and why they're not just a lift and shift approach. And we're both totally grateful for this space to introduce and receive feedback from you on the work that we're offering out. So I'll just pass over to Chloe to introduce herself and then come back.
Thanks, Georgie. I'm Chloe Stewart. I'm a health psychologist, and I hold a role in Sussex as the clinical head for personalised care, hence why I'm so linked and invested in the work that they've been doing within the MSK service. But I also hold a role with NHS England as a national clinical advisor in personalised care, but focused on MSK. I'll hand back to you, Georgie.
Thank you. Next slide. So we wanted to start with a CAD story to bring the approach more to life. And the heart of a CAD is what makes it different. And that difference is the people. It's about connecting to the whole person and teams and way beyond. So to show you what that really means, I just want to tell you a story about Jean. So Jean was someone that I saw in the What Matters to You section of the CAD. So she's 75 and she was referred for thumb and hand pain, and she was told it was just wear and tear. And she sat down with me in the What Matters to You space, and there was like an icy edginess about her. When I asked her what mattered most to her, she said, well, I've come because I was told to. So you can tell me what's wrong. And she talked about the things that she could no longer do, her hair, her makeup, and things that really mattered to her. When I asked her again what she really cared most about, like what she thought, believed, and needed, she paused. I don't know, she said. I guess nothing can be done. I'm ancient. I just hurt all over. It felt like in that moment, time slowed down and a door within her was starting to open. She could see that I cared. I was curious. She then said, I don't know, I'm sorry I'm being difficult. I just get on with it. I think I've just given up. And in that moment, we both knew that there was something else beyond the pain that she was experiencing. So I gently asked if she'd ever spoken about what she was feeling or thinking, or what was beyond this line of this waterline. That's when her story started to unfold. It wasn't just arthritis of her thumb. It was post-traumatic stress disorder. It was anxiety. It was isolation. Her pain was tied to significant trauma, years of abuse from her late husband, stuff she hadn't even spoken to anyone about before. And she let me know, in fact, she'd not spoken to anyone in weeks about anything. She mentioned suicidal thoughts as if they were just normal, everyday things. She didn't come in for a thumb spin and exercises, although that was part of what she experienced because it mattered. She came in needing to be seen and needing to be heard as a whole person beyond her thumb pain. And because I feel cared for in my work, because my colleagues create a space where I feel valued, seen and supported, I felt able to care for her. That care just flows outwards. Because I cared, because I was curious, because I was unhurried, I could connect with her. We went to the community hub together and she found others who cared too. Like what Sam said, it was hand to hand, a face to face. The social prescribers, the wellbeing team, charities such as the Brighton Women's Centre, places she would never have reached herself. And if I'd referred her, she would never have gone. Her pain didn't vanish that day, but she left with something way more powerful, right? She left with a sense of hope, human connection, the sense that maybe she didn't just have to get on with it. Next slide, please. So CADs should feel different. it's not a lift and shift, and it's not just a checklist that we're going to offer. It only works when the culture is grounded in the 3 C's: connection, curiosity, and care. It feels like, if it feels like your usual clinic, it's not different, which sounds totally obvious. But if we need, we just really need to be careful not to carry over old habits into a space that really is designed for change. The checklist we've created, which Chloe's going to walk us through in a second, won't work if we just stick to traditional ways of working or what MSK physio used to look like. CADs should feel different. It should feel a bit uncomfortable, and it should feel like you're sort of stepping into a different space, because it should feel like you're being vulnerable, because being vulnerable is being human. So we've seen where clinicians couldn't say what truly mattered to the person in some CADs, what they felt or believed, and that's not what matters to you, and that's not CAD. So I'm just, we're just kind of touching on the benefits of CAD, and if you want those benefits, it's not a copy and paste approach. So Chloe, I'm going to pass over to you.
Thanks, Georgie. So Jean's story really reminds us that while someone might come in for a thumb or for their blood pressure, that they're often carrying a lot more, whether that's trauma, like in Jean's case, loneliness and fear. And that's why, with the help of Georgie and the Sussex team, within the GIRF team, we've worked with them to develop this implementation checklist. Now, it's not complete, it's a work in progress, and we really need your help. But equally, it might look like a form, but it's meant to be so much more than that. And it's a way of building that mindset that Georgie's spoken to, and an environment for days like Jean's. So if we can move on to the next slide. The checklist is structured around 8 key domains, and you will receive this within the slides that you get. It dovetails onto the essential ingredients that Laura shared with you right at the beginning. And there are 8 key domains. So the first one is demedicalising and humanising care. Then ensuring visibility and access. Building the right multidisciplinary team. Sharing resources, both with patients, but also with our staff and our wider colleagues. Building a reflective and learning culture. Spaces that are designed with and for our communities. Being purpose-led and equitable. And finally, monitoring, evaluation and adopting as we go. So this is meant to be a prompt. It's really not meant to be a prescription. It's just a way of supporting you if you're thinking of going on this journey, or you're already on it and it doesn't quite feel right. It's a practical tool to help you design community appointment days that feel genuinely different to routine care, as Georgie has said. Because Jean's story shows us what's possible when we create space, not just for treatment, but for trust and connection and healing. And we hope that the checklist helps you and your teams do exactly that, with clarity and with compassion, and hopefully with just that little bit more confidence. Next slide. This slide is really just to say that this isn't the soft stuff, although sometimes it might feel as if it is. This is the heart of culture change, and it's what makes CADs what they are. When teams have space to reconnect with the authenticity of care, everything else shifts. People like Jean feel seen, and people like Georgie and I, staff, feel motivated, and the experience becomes human again. And research is really clear around beliefs about compassion. They predict a professional's motivation to care. And when people feel cared for, actually they often need less from us. So this isn't about adding more, it's really about showing up differently, as you've heard from all of the speakers today. True integration starts with unhurried, kind attention and the relationships that grow from it. Next slide. This is my final slide, really. Just that we really value your feedback. I know that I've just put up the checklist really quickly there, and as I said, you will receive it, but we really want this to be an iterative process. We want to make sure that we create something that's practical, that's usable and grounded in your real life experience. So whether you're already delivering a CAD or just exploring the idea, Your reflections will really help us shape something that is usable. So we'd ask you to scan the QR code. You can do it now or later. And to complete the short survey will only take you hopefully between 3 and 4 minutes to give us that feedback. Thank you so much for your time today, for listening and for everything you are doing to make this a reality. And I'm going to hand over now to Luke, who's going to take your Q&As.
That's great stuff. Thank you so much to all our amazing presenters for a really, really rich and varied and informative presentation. I have been monitoring, again, all the questions that are coming in the Q&A during this time. And just to assure people that the slides that you see presented will be coming out probably shortly, later today. Also, if you have colleagues who've been unable to attend the webinar for whatever reason, we've got an amazing team with Mandy and Sophie that are on the call, who will probably have on the GERF website this up, I think via YouTube now, so that you can see, so that you can encourage people to share, and please do. So a couple of themes, and again, can see the panel all popping up now, of the questions that are coming out the Q&A, and just guys, just let me know who you feel is best to offer an opinion on this. There's been a lot of chat about, I guess, sort of local private practice, as well as things like podiatry. And I know there was a specific question for Sam about how you involved your local podiatrists in these events. Can I put to the panel, in terms of I guess other professions that might not be seen as sort of most traditional sort of I guess physiotherapy or occupational therapy, how those are considered for these sorts of events? Laura, do you want to come in?
Yeah, so we absolutely had podiatrists in our team. So our team was very eclectic. Probably we had osteopaths, podiatrists, pelvic health. We had nursing staff. George, you might need to help me out, but basically social prescribers. So we had a range of people. And for me, whilst this is about MSK, there is absolutely no reason why this cannot be from any speciality. And you know, I think one of the things we should be looking at is broadening it out, because you know, often you know, the MSK piece is just one part of the puzzle. You know, people will have other comorbidities, and we know the connection between cardiovascular disease and diabetes and OA. You know, for me, that would be the dream to put something like that together, because I think that could work really well.
Thank you so much, Laura. Did any of the rest of the panel want to come in on that, or
I can just
happy?
add to what Laura said. You know, at one point we had like physiotherapy students, nursing students, podiatry students, you know, so that was just incredible for them to be part of the growth of something different. We had GPs at one point, so any lumps and bumps, you know, that was just great that we could just hold those in that space. We had, you know, like with the nursing aspect, you know, there were situations where we had infections and things like that that people wanted to speak about, because we kind of, as you build trust, people want to speak more and uncover more of what's going on for them. So it absolutely speaks to the need to have as many, like what Laura says, as many services as possible that could possibly come from an MSK and beyond, or a person.
Thank you so much. So leading on quite nicely from that, there was a question that I was interested in, and you know, in terms of a multidisciplinary presence, about having vaccinations offered at these days and fitting in with vaccination programs. Is that something that has been considered, applied, is in the thinking going forward? And again, just
so the answer is yes. So we've definitely are in conversation about having flu jabs there, COVID jabs, and I think you've got a critical mass there, right? And so it's a really great opportunity to do things like that. And the same with the health checks. For me, you've got loads of people in the same room that could be having these things, and the number of people that we've picked up with who are pre-diabetic, have got really high blood pressure. You know, we've had to blue light people to the hospital as a consequence of some of these things. So, you know, here's the opportunity to do those things whilst you're there in the room.
Yeah,
that's great.
Sorry,
no, please do.
Sorry, yeah, I was going to say, yeah. So we had that presence and that facility, if that's right, upstairs within our sort of our main setting. And actually, sort of Laura said, actually, it's that whole pathway, isn't it? And what we quite often see. So we had a range of lists that either people were sort of pre-booked, and sort of we had a volume of people that would come in for those interventions. But also what we found is in terms of some of those conversations that we had those sort of unintended consequences. So then sort of phrase opportunities to discuss about vaccine status and sort of vaccine hesitancy. And that's, I think, again, those key messages in terms of actually people quite often come in to us, certainly talk about housing or money and finances. Then actually once you have that person, there's again the conversation come about, that then opens up conversations about health. And actually then if you have those facilities on site, actually can be easily directed to. And again, as I always say, similar to our search in terms of a range of different forms on site to then manage that. So yeah, actually I think it's a fundamental way to sort of how we conclude that whole way.
Amazing stuff, thank you. So, final question on this, because it's a bit of a cluster, but it came through as a theme in the Q&A, is mental health services, patients needing mental health intervention, thinking about Georgie's example that she gave there. How have you found accessing mental health services for these days? Have you been able to provide it? And what would be your thinking on sort of going forward, how you bring those services together? And again, please.
We've been very fortunate in Cornwall because our trust is not just physical health services, it's combined with mental health services as well. So we've been very fortunate to link with our colleagues in the same trust and invite them to come along and hold a day with us, as Sam explained. And that's been really, really helpful because I think they're probably utilised more than any other service. We probably have, they're utilised more than any other health service, if you see what I mean. And also the community village. I can't stress enough how the demedicalisation of these days is so helpful, and it's definitely the way forward, how we need to work in the future. I think we need to move away from needing clinical specialists there from different disciplines and more towards accessing what's available in the voluntary and community and social enterprise sector.
Well, I will add to that as well, is that having mental health experts there on the day, we did have at one of our CADs the presentation of somebody who felt that they were close to mental health crisis. And actually then we were able to immediately put the support around the patient to be able to help them, and we were able to deal with that. You wouldn't have had that if it was just MSK professionals in that room. So yeah, being able to react in the moment as well is fantastic.
So final question to the panel for me, and we're running out of time, so I'm going to make it 2 questions in one, but a couple of things have come out as themes in terms of the financials and then also the marketing of these events and where people could get more information about how you have approached those. So please just chip in, but if we could leave Andy 1 minute at the end to sum up, that would be great, please.
I mean, I can talk to marketing is really, really challenging, right? Because actually we felt that we'd told people what to come and what they would expect. We signposted them to our website and said, here's what's going to happen when you come in the room. These are all the things that you know will happen. People were coming to the event and they kind of come and go, well, what's this all about? Why am I here? And we're like, oh, okay. And actually, when we then sort of put people in stewarding kind of roles where we'd say, have you opened your link? Yes. Have you read the information? No. So, and then they would be told, well, this is what's going to happen. This is what to expect. Do you want to continue? And most people would say yes. There are a few people that couldn't function in that space, and that's fine. So we were able to pull those out and do something differently. So I think the marketing's challenging because it's different for people. It's not what they expect, and it's very important to kind of steer them through that process. And we made sure we did that the whole way through the process. There's always somebody there to help navigate the kind of what was going on for them. So for me, really, really critical part of that day. What was the other question? Something about financials?
About the finances. I thought they were in our case study, Laura. There is a
yes,
CAD
there
case
is.
study
Yeah,
that we produced with.
Yeah, and I can provide some information around that. I think there is a cost for sure, and it's a challenge. Is a challenge, but actually, if you trade it, there's you actually reduce the number of follow-ups that people need quite significantly. So depending on how you look at that financial sort of envelope, it does work, but it needs a bit of playing around with, probably, I suspect.
Okay. Thank you, Laura. Well, wow, I think that was one fascinating webinar. Once again, I'd like to thank you, everybody who's enabled this to happen. And I'd like to thank Luke for facilitating the questions and reiterate, we will look at these and try and respond. Look, I think there's a massive challenge we have in the health and care space, and we have to be creative about how we best use our resource, and we need to collaborate to ensure that we really help people. And I think this is a new way of working, reasonably new, 2000, it's 2023, but it's a new way of working that in Girth, we want to support develop, and we want to help this evolve, and we want to try and help integrate this way of working, not only to the framework of delivery of MSK conditions, but wider, as we've talked about. And so that's the ethos behind our checklist. Please, please, please have a look at it. It is a first stab at this. It's not the only stab. It's going to take time. It's going to evolve, and we need to evolve this as a collaborative. And I hope this webinar is a start of that process. So thank you, everyone. Have a lovely afternoon, and we look forward to seeing how this further moves.